Okay, hello everyone. Welcome to this class on Mission FMGE short subject revision. I hope you guys are able to see me and hear me well. Today we'll be doing the whole of anesthesia in 2 hours. So our first class is from 7 to 8 p.m. and our next class is from 8:30 to 9:30 p.m. First things first, this series, we are going to complete all the short subjects in 1 week. So all of you who have missed yesterday's lectures, so I have already taken DERMAT yesterday, part 1 and part 2, and we finished DERMAT yesterday. Today we'll be doing anesthesia. Then on Saturday we'll be doing radiology. On Sunday we'll be doing psychiatry. And orthopedics, what I'm going to try to do is a little bit of it tomorrow and a little bit of it on Sunday. I will keep you posted about orthopedics, but that is also there in one of the classes. Okay. So if any of you have any doubts about this series, please do let me know, because I'm putting in a lot of efforts to make sure that you guys revise all the subjects before the exams. Also, we have a medicine revision series that is going on. Yesterday, I have taken endocrine. We have already finished rheumat, hepatobiliary system, nephrology. All that is done, and we are left only with, and connective tissue disorders. We are left only with cardiology is also done. We'll next week we'll be doing neurology, respiratory system, and miscellaneous. Okay, so yes, total anesthesia will be finished today in the 2 classes itself. So let's start with our class for today. So welcome to the Plus subscription on Unacademy. It will give you access to both live and recorded classes. You can learn from India's top educators. You can compete in live tests and quizzes and access our question bank with 25,000 plus questions. The iconic subscription is a partnership between Unacademy and Prep Ladder, which will give you the best of both worlds. And these are a few INI-CET tests that we have. This is not an MCQ session. This is going to be, if I start taking MCQs, it's going to take a long time to complete the entire portion. So I am going to mainly be talking and you guys will be answering some of the questions, but there is no MCQ. I don't want to waste 30 seconds waiting for you guys to answer. Okay. All right. So in our special classes, if you see on the right hand side, if you're using a desktop, you have a raise a hand option. So you can raise your hand and ask me questions from there. And don't forget to download the PDF at the end of the class. Absolutely, INI-CET people can also attend this lecture. It will be very, very useful for all of you also. We have a question bank, NEET PG toppers, and some of our plus courses that are going on. Clinical case discussions and instrument batch. Target next integrated batch 2023 and 2022. And this is my code Dr.Jhanvi Live. If you want to join the Plus platform, you will get a 10% off on your subscription. All right. So let's begin with our first slide for today. So can anyone tell me the full form of what is this instrument and all these instruments and their names? So what is this instrument that we are using it? What kind of device is it? Yes, this is called as the laryngeal mask airway. What is the other name of a laryngeal mask airway? Other name of laryngeal mask airway. The faster you guys talk, the more we will be able to revise. Okay. It is also called as a supraglottic airway device. Supraglottic airway device. Okay. Now, in the laryngeal mask airway, what is the question that they ask? First of all, they will ask who is the founder. So that is Dr. Archie Brain, who is the founder of laryngeal mask airway. Okay. Second thing, they will ask you to identify the different types of laryngeal mask airway. So can you tell me which one is 1, which is 2, which is 3, and which is 4? And then we have 5, 6, and 7 also over here. Okay, very good, Ashutosh. So he has identified the first one correctly. So look over here. Can you see that there is a single tubing coming out of this LMA? This is the cuff of the LMA. This is the pilot balloon which will inflate the cuff of the LMA, and this is a single tubing which is nothing but the airway tube coming out of the LMA. Okay, so if you have a single tubing, this is a first generation LMA, and the only first generation LMA asked in the exam is LMA Classic. Okay. Next, we have over here 2 tubings that are coming out. So you have the big airway tube over here, and behind you have the gastric tube. Okay. So if 2 tubes are there, this is a second generation LMA. So can anyone tell me the name of the second generation LMA? It is a disposable second generation LMA. Can anyone identify this for me? What LMA is this? LMA Come on, very good, Dr. Priyan. This is your LMA Supreme. Okay, so two tubings are there. It has a bite block and it is a disposable type. Okay, now this LMA that you can see over here, which has an endotracheal tube along with it, and it also has a steel handle to hold it, and it is made up of silicon. So if it is made up of silicon, it is non-disposable. So can you tell me what is the name of this non-disposable silicon LMA with an endotracheal tube in it? This is not Procil, Preeti. Okay, why does this specifically have an endotracheal tube in it? It helps in intubation. Okay, so this is also called as your intubating LMA. The other name for this LMA is LMA fast track. LMA fast track. Okay, so in your exam, if they ask you for intubation which LMA is useful, remember the name of the LMA. It is called as LMA fast track or intubating LMA. Short form for intubating LMA is ILMA. Okay. Next, over here, can you see this LMA? This has features of both LMA and endotracheal tube. So you will see over here, it is very big as compared to an endotracheal tube, and it also has a cuff attached over here. So can you tell me what is this? This is not an LMA. This is a different type of instrument. Any idea what this is? Okay, I'll tell you what it is. This is called as a laryngeal tube. Laryngeal tube. Okay, so you put it like an LMA and the function is like an endotracheal tube. So both mixed in it, it is a laryngeal tube. Okay, so all different types of LMAs on this slide done. Next, can you identify LMA number 5, LMA number 6 and LMA number 7? So again, you have over here two tubings that are coming out. So this is your airway tubing, this is your gastric tubing, and again you see that the cuff is made up of silicon. So whenever the cuff is made up of silicon, this becomes a non-disposable LMA. So any idea which LMA is this? Non-disposable LMA, very good, Muan. This is your LMA Pro-Seal. Okay. Now, very important question about LMA Pro-Seal that they ask in the exam. The LMA most preferred in daycare surgery. In daycare surgery is LMA Pro-Seal. Okay. Now, can you tell me what is daycare surgery? Can anyone tell me what is daycare surgery? Okay, I give you an example. Suppose I have to get operated for some small surgery. Maybe there is some problem in my ear and I have to get operated. Okay. So the doctor surgeon tells me that, madam, you come at 7 p.m. and I will operate you at around 9 p.m. and I will discharge you by 1 a.m. at night. Is this daycare surgery or not? Is this daycare surgery or not? He is going to admit me at 7, discharge me at, operate on me at 9 and discharge me at 1 o'clock in the night. So this is not daycare surgery. Okay, daycare surgery is the one in which you get admitted, operated and discharged on the same calendar day. Please remember this. Okay, daycare surgery, same calendar day. So I have to get admitted on that day, operated on that day and discharged on the same calendar day. If I'm getting discharged at 1 o'clock in the night, the date is changing, correct? It's the next calendar day. So that is not daycare surgery. All right. Okay. Now next LMA, you see over here again two tubings. This one is the airway tube, one is the gastric tube, and this is fully green color LMA. So any idea what is this fully green color LMA called? Anyone, any idea? Okay, this is called as the Ambu LMA. Ambu LMA. Okay. And last that we have over here 7. This is a very peculiar type of LMA. So here what is the missing thing over here? If you see in all the LMAs, there is a cuff and this cuff is inflated by this pilot balloon and pilot inflation line, correct? So what is missing in this last LMA over here? Cuff is there, pilot balloon, cuff, pilot balloon is there everywhere. So in this last LMA, what are we missing over here? Any idea? Dekho, is there a pilot balloon over here? No, correct? This pilot balloon, this is absent over here. So does that mean that this cuff needn't be inflated? Yes. So this is a special type of LMA. It is called as a Igel Lma. Okay. So what is the use of Igel Lma? This Igel Lma, this part, the cuff is made up of a thermoelastic material. Okay. So what it does is once I put the LMA into the throat of the patient. It will take the heat that is present in this area. Okay. Once it takes the heat over here, it will expand and the LMA will form a seal with the vocal cords. Correct? So it does not require any air to inflate the cuff. It just takes the heat and it expands. Okay. So all different types of LMA seen. First generation LMA, LMA classic. Others are all second generation LMA. Supreme, intubating LMA, laryngeal tube airway, ProSeal LMA, Ambu LMA and Igel Lma. Okay. Now about LMAs, one more question that they will ask you in the exam is what LMA size for what weight of the patient. Okay. So you have to remember only three main sizes of the LMA. First size is the smallest size that exists. So the smallest size that exists is the smallest human being. Who's the smallest human being? It is a neonate. Okay. This is a neonate. So neonate is usually less than 5 kg. Okay. Next size you need to remember is size 3 and size 4. So size 3 ke baju mein just write 3 again over here and add a 0. So 30 to 50 kg mein you will use size 3 and next is 50 to 70 kg. Usme you will use a size 4 element. Okay. So these are the three main sizes that you need to remember. So if they ask you in a neonate, what size do you put? Size 1. Adult female is usually size 3 and adult male is usually size 4. Okay. Now other than this, you have small sizes. 1.5 is for 5 to 10 kg. Size 2 is for 10 to 20 kg. And size 2.5 is for 20 to 30 kg. If you can remember, good. If you can't remember, it's absolutely fine. If you don't remember these sizes, they will not ask you in the exam. Okay. All right. Now, next, moving on to the other instrument that is very frequently used in anesthesia. So, can anyone identify this instrument? Yes, very good, Akshat. This is a laryngoscope. What is laryngoscope used for? What is the procedure that laryngoscope is used for? Very good. Laryngoscope is used for intubation. Correct? It is used for intubation, for putting an endotracheal tube inside the patient. Now, do you know the parts of the laryngoscope? This is called as the blade of the laryngoscope and this is called as the handle of the laryngoscope. Here inside the handle of the laryngoscope, you will be having batteries and there is a small torch over here. I'll zoom in and show you. So those batteries will light that torch. Okay. So whenever you look inside the airway of the patient, that torch will light up and it will show you the vocal cords. So you put the laryngoscope inside, lift it up, down you will see vocal cords and then through the vocal cords you will pass the endotracheal tube. Okay, clear? So this is your laryngoscope. Now you should be able to identify the different types of laryngoscopes based on how they look. So can anyone tell me the name of this laryngoscope? It has a curved blade and it has a lever over here. Yes, very good, Arjun. So this is McCoy laryngoscope. Okay, this is not Macintosh laryngoscope. Which one is Macintosh laryngoscope? Just a simple curved blade is a Macintosh laryngoscope. Okay, your McCoy laryngoscope has a curved blade plus a lever. This is important. Now, what is the use of this lever? So what happens is if you push this lever down, if you push the lever down like this is the flexible part of the laryngoscope. This will move up like this, okay, and it will show you the vocal cords down. So this lever helps in visualizing the vocal cords, okay. So this is your McCoy with curved blade and lever. Only curved blade, no lever is your Macintosh laryngoscope, okay. Now, which is this laryngoscope with a straight blade? Very good, Amodini. So this is your Miller's laryngoscope. Miller's laryngoscope. Now, what is the specific thing about Miller's laryngoscope? Anyone? Yes, very good. It is used in children for intubation. Okay. All right. And then the last one that you can see over here. Can anyone identify this special type of laryngoscope used nowadays? You can use the laryngoscope and you can see the vocal cords of the patient in the video. Yes, very good. This is called as a video laryngoscope. CMAC is the name of the company. The type of laryngoscope is a video laryngoscope. So you're seeing the vocal cords over here. Can you see over here? Sometimes they ask you this in ENT to identify. So you can look at the picture. your vocal cords will be whitish over here. Okay, and then this is your big leaf shaped epiglottis, and behind you will have your arytenoids. Okay, so this is the picture of the vocal cords, and you will pass your tube from here. Okay, all right. Now different types of endotracheal tubes and their identification. So the first tube that we have, yes, these are all endotracheal tubes. So can you guys identify for me this tube over here? Sabse pehle, this tube that I have marked over here, can you identify for me? I'll mark it in numbers 1, 2, 3, 4 and 5. So what is tube number 4? Yes, don't say it is endotracheal tube. All of them are endotracheal tubes, but tube number 5 is your specific endotracheal tube, which is made up of PVC. PVC is nothing but polyvinyl chloride. Okay, so this is your most commonly used endotracheal tube. It is disposable type. What are the parts of this endotracheal tube? So you have a cuff over here. Okay, and then you have a radio opaque line over here, black line, which will be radio opaque, which will tell you the position of the endotracheal tube on X-ray. This is the universal adapter which is connected to the circuit. This is the pilot inflation line and the pilot balloon, which is helping in inflating the cuff. Okay. Now remember one very important thing that they ask in the exam. There is an opening over here at the end. Can anyone tell me what is that opening present at the end? What is the name of that opening? Other than the end of the tube, what is the name of the alternate opening? Yes, very good. It is called as the Murphy's eye. What is the use of the Murphy's eye, anyone? Okay, so if the end of your tube is blocked, suppose there is some secretion and the end of your tube is blocked, so there can be alternate ventilation out of this Murphy's eye. Okay, so this will provide a place for alternate ventilation. Clear? Alright, now identify tube 1 and tube 2. Anyone? Tube 1 and tube 2. So tube 1 you will see it is angulated like this, like a right angle, and tube 2 is angulated like a S. If I may continue this, this can become a S. Yes, so tube 1 with a right angle over here is nothing but your north pole tube. And tube 2, which has an angle like this, which almost forms an S, is your south pole tube. Okay. Now, what is the use of your, and both of them are called as RAE tubes. RAE, you don't need to know the full form, but they are three scientists, Ring, Adair and Elvin. Okay. So, Ring, Adair and Elvin tubes, north pole and south pole tube. So, what do these tubes basically do? Now imagine I have a surgery of the mandible. In this area, I have a surgery to be done. So if I put the endotracheal tube like this, it comes out from my mouth like this. Okay. Now the surgeon is trying to operate over here and his hand keeps coming here near the tube. Tube can cut, it can get compressed. So what do? I take a tube which comes out like this and turn it like that. So I'm turning it towards the north. So this becomes a north pole tube. Or I take the tube and turn it down like this. So if the turn is like that, it is called as the south pole tube. Okay. So that is how your north pole and south pole tube look like, and that is the use of the north pole and south pole tube. If you're sharing the airway area with the surgeon, then you will use these RAE tubes or north pole and south pole tubes. Okay. Now in tube number 3, do you see anything specific over here? Something is missing in tube number 3, anyone? Yes, very good. There is no cuff. There is no cuff present over here. Okay. So what is this tube? This is called as an uncuffed tube. So in whom do we use an uncuffed tube? Uncuffed tube is used in children. Okay. It is used in children. Why is it used in children? So if this is the vocal cords, okay, and you put the tube like this down. Now if you inflate the cuff, the end of the cuff will come like this, just below the vocal cords. Okay. In children, what happens is your larynx is almost straight and it is narrow. So you put the tube like this, and if you inflate the cuff has no place to inflate and it puts too much pressure on the trachea. So this trachea can get damaged. Okay. So you want to avoid that damage in the trachea. And that's why, what are you going to do? You are going to use a uncuffed tube. So you will not use a cuffed tube. You will just use a uncuffed tube in children. Okay. All right. And the last tube over here, tube number 5. So tube number 1 is North Pole tube. This is South Pole tube. This is uncuffed tube, and this is normal PVC tube. Now, can you tell me what is this tube? Both are the same tube, and it is similar to tube number 5 over here. Admer, no, yes, it is a armor tube. Okay, this is a armor tube. What is the other name of the armor tube? It is also called as the flexometallic tube. Okay, now what is the use of the armor tube or the flexometallic tube? So just look at the tube. Can you see small metal wirings inside? Are you guys able to see small metal wirings inside? Okay, so what happens with those small metal wirings? Those small metal wirings make the tube flexible. So even if I turn the tube like this, or I crush the tube like that, because of the metal wirings, the lumen that is there of the tube, the cavity of the tube remains intact. It does not get compressed, it does not get kinked, it does not get torn apart. Okay, so this is your flexible metallic tube because of the rings inside. So this is called as armor tube or flexometallic tube. Okay, and this one has been asked previously in the FMGE exam. Can anyone identify this tube? It has two ends, it has two cuffs over here. To inflate these two cuffs, there are two pilot balloons over here, and it has a slight angle over here. Yes, very good. So this one, everything is double over here. Two ends, two pilot balloons, two cuffs. So this is also called as a double lumen tube. Okay, so your double lumen tube has a very specific use. So suppose these are my lungs, and imagine there is a tumor in this side of the lung. Now if I want to operate on this lung, I have to deflate it. The lung has to be deflated. Okay, but on the other hand, to oxygenate the patient, the other lung needs to be inflated, correct? So how do I do this? Whenever I put an endotracheal tube, it goes in the trachea and it supplies oxygen to both the lungs. Okay, but in this specific thing, what I have to do in this kind of surgery, this is called as thoracic surgery, I have to do one lung ventilation. I have to keep the operative lung deflated and the other lung inflated to oxygenate the patient. Okay, so what do I do in this case? I use a double lumen tube. So if you can watch over here, the double lumen tube will basically enter into the trachea and take a turn like this. Can you see the turn that is coming, the curve that is coming over here? It will take a turn and it will provide ventilation to one side lung. The other side lung will not get ventilated, so you can operate on it, and this side lung will get ventilated. Okay, so double lumen tube is used in thoracic surgery for one lung ventilation. All right, so we've done what till now? All are different types of LMAs. We've done all different types of laryngoscopes, all different types of tubes. Okay, now we go on to all different types of airway adjuncts. So can you guys quickly identify for me what is adjunct 1, what is adjunct 2, what is adjunct 3, and what is adjunct 4, and what are they all used for? Yes, very good. The adjunct 1 that you guys can see over here, this is nothing but a Giddels oropharyngeal airway. Giddels oropharyngeal airway. Okay, now why is this used? So let me zoom in and show you. Can you see how this oropharyngeal airway is inserted? You're putting it in the mouth of the person and then it goes down like this. So what it does is it pushes the tongue forward and creates a passage over here for air to pass. Okay, so this is your Giddels oropharyngeal airway. Similarly, the same thing you can do through the nose. So you put the tube through the nose and it will create this passage for air to go inside. Okay, so this is called as your nasopharyngeal airway. So instead of putting it through the oral cavity, if you're putting it through the nasal cavity, then this is called as your nasopharyngeal airway. Clear? Okay. Now what is 3 and what is 4 over here? Anyone, what is 3? 3 is called as a bougie. Okay, this is called as a bougie. What is the use of a bougie? Suppose my vocal cords are here. Okay, instead of seeing the whole length of the vocal cords, suppose, and this is my epiglottis, these are my arytenoids. Now, suppose this is the view that I'm getting, very less of the vocal cords and the arytenoids over here. So what I do is first I pass the bougie inside. It's a very thin, slender tubing. First I pass the bougie inside, and then once the bougie is in, on top of the bougie I pass the big fat endotracheal tube. Okay. Once the endotracheal tube goes in, I remove the bougie out. So bougie helps me in intubation. Clear? This bougie will help me in intubation. Okay, understood? If someone has not understood, please do let me know. Or if I'm going too fast, please do let me know. Okay. Now, this second thing over here is called as a stylet. Stylette. What is the use of a stylet? Now, suppose this is the view that I'm getting. So you have the epiglottis, you have very less anterior part of the vocal cords, and then the arytenoids. So what I do is I take my endotracheal tube. Through the endotracheal tube, I pass this stylet. It's a stainless steel rod, and then I angulate this rod. Including the rod, I angulate the tube forward. Okay. So when I angulate the tube forward, it goes forward into the vocal cords. These, you may have seen Shah Rukh Khan has a very big larynx which comes ekdam aage aise, like this. Okay, his Adam's apple is very obvious. That means his vocal cords will be very anterior. So if I'm intubating Shah Rukh Khan, if I get the good luck of doing that, so I will use this stylet at that time to curve the tube. I will curve the tube very well so that it goes directly anteriorly to the anterior vocal cords. Okay. So these are all my airway adjuncts: oropharyngeal airway, nasopharyngeal airway, bougie, and stylet. All right. Okay. Now, what is this? Anyone? What is this picture over here? Yes, this is my anesthesia machine. Now, can you tell me if I can use the same machine in the ICU? For critical care patients, can I use the same machine or not? Yes. So this cannot be used for critical care patients at all. Okay, you need to know little of the parts of the machine. So here I will mark for you guys parts, and you have to tell me what are these parts. So what is 1, what is 2, what is 3, what is 4, then what is 5, and what is 6. And also tell me the use of all of them. Yes. So 1 is your vaporizer. Okay. Now, about vaporizer, you need to know 2-3 things. So first you need to know the color of the vaporizer and what gas it contains. Okay. So all your anesthetic agents that we have, these anesthetic agents are all present in the liquid form. So what do you do in the vaporizer? You take the anesthetic agent that is in the liquid form, and then the vaporizer will convert it into vapors. Okay. From the vapors, you will have oxygen and nitrous oxide. These are the carrier gases. They will pass through the vaporizer, and they will carry the vapors of these inhaled anesthetic agents along with it. Okay. So once these gases enter into this, they will be only oxygen and nitrous oxide, but they will go ahead and they will become oxygen nitrous oxide plus sevoflurane or whatever anesthetic agent is there, uska vaporizer. Okay. All right. So this is vaporizer. Next thing you need to know is colors of the vaporizer and what gas does it contain. So here you can see you have red color vaporizer, purple color vaporizer. So can you tell me which gas is there in this? In red color vaporizer, in purple color vaporizer, in blue color vaporizer. They ask all this, gas and which vaporizer is there. Yellow color vaporizer. Okay. So red color vaporizer has halothane in it. Purple color vaporizer has isoflurane in it. What does blue color have? Anyone blue color? Yellow color is sevoflurane, absolutely correct. What does blue color have? Blue color has desflurane. Very good. Now, because we have written the names of all these gases, can you also tell me the MAC of these agents, the minimum alveolar concentration of these agents? Halothane MAC, 0.75, very good. Anyone who wants to learn the max easily, I have taken a video on YouTube that is a freely available video on mnemonic of MAC of the agents. Okay, so I have given very nicely mnemonics for all these agents and how to remember the MAC. Okay, isoflurane is 1.4, desflurane is 6, and sevoflurane is 2. Okay, so these are all the MACs of our agent. Okay, what is the gas with the minimum MAC and what is the gas with the maximum MAC? Sometimes they ask this in the exam. Minimum MAC, methoxyflurane has the minimum MAC. Very good. What is the MAC of methoxyflurane? It is 0.16. Okay, 0.16. And what is the maximum MAC? This also you know the agent. This agent we are using it over here. Is it nitrogen? Is it nitrous oxide? Is it nitrous dioxide? Is it nitric oxide? What is it? Yes, it is nitrous oxide. Okay, everyone will write N2O, but when it comes in the exam, they will mark nitric oxide. Okay, so it is nitrous oxide. What is the MAC of nitrous oxide? It is 104. Okay, so gas with minimum and maximum MAC. Okay, one more gas you need to remember. Just remember this name. The gas with the minimum blood gas partition coefficient. Just remember the name. Ratta maar lo ye, theek hai? What is the gas with the minimum blood gas partition coefficient? It is desflurane. Okay, clear? Alright. Now, moving on again to our parts of the machine. Now, what is this glass tubings that I have shown you over here? These glass tubings that I have shown. Anyone? They are the flow meters. What is the work of the flow meter? Anyone? What does the flow meter do? The flow meter will basically help me in setting the flows of my carrier gases. Okay. So what are my carrier gases? My carrier gas is basically oxygen and nitrous oxide. So with the flow meter, I can set how much oxygen or nitrous oxide I want to give. So the gases will go from here on top of the vaporizer, and from the vaporizer, they will take the vapors of the inhaled anesthetic agent. Okay. What is 3? This green button over here. Oxygen 100%, very good, Ashutosh, but what is the name of that? Oxygen flush button. Very good. Okay. So anyone, what is the use of oxygen flush? When you use the flush in the bathroom, what happens? When you use the flush in the bathroom, what will happen? The water will come with a big gush. Okay. Now, when you give oxygen flush, when you press the oxygen flush button, the oxygen will come with a gush and it will go directly into the patient's lungs. Okay. So if your patient is desaturating, if his oxygen levels are going down, you see his saturation is going down 90, 80, 70, and you cannot understand why it's happening. Just press the button and give a gush of oxygen to the patient. Okay. You will give a gush of 100% oxygen to the patient through this. All right. Now, what is these drawers? Okay, so these are nothing but drawers in which you will keep all your anesthesia equipment. You will keep LMA, intubating equipment, any emergency drugs, all of them will be kept in these drawers. Okay, what is 5 over here? Now, have you all played Jack in the Box? वो बचपन में दिखाते थे ना, if you open the box, the clown will come up like that, ऐसे suddenly, ऐसे वाला. Okay, Jack in the Box. So Jack in the Box, these are nothing but bellows. Okay. So what do the bellows do? They compress the air and they pass it under positive pressure directly into the lungs. So once the bellows fall, the air will get pushed down directly into the lungs of the patient. And 6, here you have a canister of carbon dioxide absorber. Okay. Now, can you tell me what are the carbon dioxide absorbers that are available? Which is the one that we use commonly? The most commonly used carbon dioxide absorber? Sodalite. Very good. What is the main component of soda lime? If they ask you in the exam, what is the main component of soda lime? Main component of soda lime? Calcium, yes, very good. Calcium what? Okay, I will give you options. Sodium hydroxide, calcium chloride, calcium hydroxide. What is the main component of soda lime? Calcium oxide chloride, someone has made. Okay, so the main component of soda lime is calcium hydroxide. Okay, this is the main component of soda lime. So you have different types of soda lime carbon dioxide absorber. You have soda lime, which has calcium hydroxide as the main component plus sodium hydroxide. So because of this sodium hydroxide, it is called as soda lime. The other one is bara lime. That also contains calcium hydroxide as the main component plus barium hydroxide along with it. So because of the barium hydroxide, it is called bara lime. Okay, clear? So these are the parts of your anesthesia machine. Okay. Now if you see small dials over here, these are telling you the pressures of your cylinders and pipelines. Okay. So this is nothing but pipeline and cylinder pressure indicator. Okay. Alright. Moving on to the next thing over here. Can anyone identify these circuits for me? Which is an open circuit, which is a closed circuit? I'll mark it over here. 1, 2, 3. Which is open circuit, which is closed circuit, and which is semi-closed circuit. Okay, very good. First one is a closed circuit. Second one is semi-closed circuit. And third one is open circuit. Okay. Now let me tell you what are all these circuits. So open circuit is nothing but a mask. In olden times, how they used to give anesthesia, they used to just put a mask over here. Okay, on top of the mask, they used to keep gauze pieces. So imagine they keep gauze pieces, kapda rakhte the, and then they used to put drop of ether or chloroform. So the person will inhale the ether and chloroform when you put drops of it from the gauze piece, and he used to become unconscious. Okay, so what is happening over here? All the air that he is breathing is going out to the environment. All the air from the environment is coming out. So there is complete communication with the environment. So this is called as the open circuit. Okay, so this is your open circuit. Next, what we have is your closed circuit. So this is the most advanced one that we use right now. So closed circuit this is your ventilator. From the ventilator, you will have the circuit going like this. This is your inspiratory limb. So all the gases that you want to give into the lungs of the patient. Okay. So this will be oxygen, nitrous oxide, sevoflurane, whatever gas you want to give, you can give it through this inspiratory limb. Okay. Then it will go from here into the lungs of the patient. So let me draw the lungs of the patient over here for you guys. So from here, through the endotracheal tube, it will go into the lungs of the patient, whatever gases you've given. Then from the same endotracheal tube, whatever gas is exhaled will come out. Okay. So this endotracheal tube is going into the trachea. So from here, whatever gas is exhaled will come out. Now you will say, ma'am, why is it going in one direction only? So there are valves over here, unidirectional valves. Okay. So what happens is, if I mark over here, the oxygen, nitrous oxide, CO will go like this. It will go like that into the lungs of the patient. Whatever the patient exhales out will come out through the same endotracheal tube, and it will go like this through this area, through this unidirectional valve. Okay. Now what does the patient exhale? He will exhale the same thing that he had inhaled, oxygen, nitrous oxide, CO, plus there will be one more thing that you exhale. So what do we normally exhale? We also exhale carbon dioxide, correct? So that will be the exhaled gas. Now this exhaled gas there will be a bag over here. After that, there will be presence of a carbon dioxide absorber. Okay, and then connection over here. Now what happens is this gas is going into the carbon dioxide absorber. So in the carbon dioxide absorber, all this carbon dioxide will get absorbed. Okay, so here after the carbon dioxide absorber, what are you getting? After all the carbon dioxide is absorbed, you get this. This is equal to this, correct? So what do? You are using or recycling the gases for the next breath. Okay, so you end up recycling the gases in a closed circuit. Did you guys understand, or should I explain it once more? In a closed circuit, you have fresh gas coming from the ventilator. So you have oxygen, nitrous oxide, CO, which I taught you over here. Your oxygen, nitrous oxide comes from the flow meters, and then it passes over the vaporizers and carries the CO. Okay, so it will enter into the inspiratory limb of the circuit, go to the patient through the endotracheal tube, reach the lungs. From the lungs, all the exhaled gas comes out, which is the same plus carbon dioxide. It goes through this expiratory limb into the carbon dioxide absorber. Here all the carbon dioxide will get absorbed, and eventually you will have the same thing over here what you had inspired. So what you do, you reuse these gases for the next breath. So can anyone tell me the advantage of closed circuit? I am recycling the gases, so this is cost effective. Okay, it is cheaper for me because I'm recycling the gases, and also I am causing less environmental pollution because I'm wasting less gases. Okay, all right. Now, anyone, these semi-closed circuits are also called as what circuits? These semi-closed circuits are also called as Mapleson circuit. Correct? Yes. So here you should know some of the Mapleson circuit and what are the questions asked about this. Now what is happening in semi-closed? Why am I calling it semi-closed? Now here you don't have any carbon dioxide absorber, no recycling of the gases, all that is not there. Directly this is fresh gas. This is the end of the ventilator. From here the gas is going, it is going through the circuit, going to the patient. When the patient expires gas, he exhales. The exhaled gas also comes back to the same tubing. The pressure in the tubing increases. This is a pop-off valve. When the pressure increases, the gas goes out from here. So the expired gas is going out from the pop-off valve. Okay. So what is happening? Inhaled gas is going like this. Exhaled gas is going out into the environment. So you are not reusing any gas. You're not recycling any gas. You're causing a lot of environmental pollution. Okay. So this is your semi-closed circuit or Mapleson circuit. Now, Mapleson circuit has many modifications, but you need to remember only 2 of them. Okay. So first of all, you need to know the names. It is A, B, C, D, E, F. Mapleson A is also called as Magill circuit. And you need to remember the 2 most commonly asked Mapleson circuit that are asked again and again. It is this one and this one. Okay. So this one is Mapleson D. What is the other name of Mapleson D? And this one is Mapleson F. Anyone? Name of Mapleson D? Yes, it is called as Baines circuit. How do you remember this Baines circuit? Can you see this tubing over here? In Baines circuit, you will see a white color tubing outside, and inside you will see a green color tubing. Okay, so you have a tube within a tube. So that is the best way to identify the Mapleson circuit. If you start the Baines circuit, if you start thinking of Baines circuit like this, you will get very confused in the exam. So please try to remember the small tricks that I am giving you guys to remember all these things. Okay. So this is tube within a tube. I will write it over here. So that is how you identify a Mapleson D circuit or a Baines circuit. Okay. Now, what is the question that they ask? Best circuit for controlled ventilation in adults. Controlled ventilation means you're putting on ventilator. Okay. So best circuit for controlled ventilation in adults. is Mapleson D or Bain circuit. Okay. Then best circuit for spontaneous ventilation. So when the patient is breathing on his own, spontaneous ventilation in adults. What is it? Mapleson A or Magill circuit. Okay. And best circuit in children for both spontaneous and controlled. Overall, what is the best circuit in children? It is Mapleson F. Okay, and this Mapleson F is also called as Jackson Reef circuit. F से याद रख सकते हैं Jackson Reef circuit. Okay, so this is your Mapleson F or Jackson Reef circuit. If you have a look at it, can you see over here? There is a short white tubing and there is a long green tubing. Both of them are separate over here, and it has a small bag over here. So this is your Mapleson F tubing that is used in children. Okay, Jackson Reef circuit used in children. Clear? So these are the main important questions asked about Mapleson circuit. ये छोड़ के और कुछ पूछते नहीं है. Most importantly, most commonly they ask, what is the Mapleson circuit used in children? Okay, so that is your Mapleson F. The other two important questions that they ask: best circuit for controlled ventilation in adults, best circuit for spontaneous ventilation in adults. Okay, now moving on to something which has become very important after COVID has started. So can you guys tell me what are all these devices that I'm showing you over here? The pictures of all of these HFNC, yes. So what are all of them called? What is the work that they do? They deliver oxygen, correct? So they are also called as oxygen delivery devices. Okay, they are all your oxygen delivery devices. Now, oxygen delivery devices may, can you guys tell me, if you look at this first one, okay, what does this first device have? So you can see there is oxygen that is coming from this big chamber over here. It is going through this big tubing, goes into this big humidifier. From the humidifier, it is going into another big tubing, and this big tubing is connected to the patient's nose. So big tubings and a humidifier. So what is that? The first one over here is your high flow nasal cannula. High flow nasal cannula, or it is also called as HFNC. Okay. Now you have to tell me how much is the maximum oxygen that your HFNC can give. How much percentage? What concentration can it give? 100%. Okay. Alright. The second one over here. So I'm marking first, second, third, fourth, so you can remember. Second one over here, you will connect it to a normal flow meter and you'll put this into the nose of the patient. You must have seen this many a times in movies, in normal ward patients, they will have this. So what is this? Very good. This is your nasal cannula. Anyone maximum flow of oxygen and maximum FiO2 given through a nasal cannula. Your maximum flow of oxygen that you give is 70 liters per minute. Yes, so through the nasal cannula, you give a maximum of 4 liters per minute and maximum FiO2 given is 40%. Okay, they ask you this in the exam. What is the FiO2 given by this oxygen delivery device? Okay, now this mask over here, what is the name of this mask? You connect this to the flow meter and you put this mask on the face of the patient. So what is the name of the mask? What is the FiO2 given with it? And maximum flows given. Laryngeal mask. No, Arjun. Laryngeal mask was the first slide that we saw. Yes. Very good, doctor. I can't see your full name. I think Pratibha. Dr. Pratibha. Okay. So this is Hudson mask. It is called as face mask or it is also called as Hudson mask. Okay. Maximum flow that I can give of oxygen is 15 liters per minute and the FiO2 given over here is 60%. Okay. Alright. Next one over here. If to the face mask or the Hudson mask, I attach this bag. This is a reservoir bag which will keep some oxygen in it. So what is this called as? Ambu? No. Ambu to wo hota hai na, press karte. What is this mask called? This was asked recently in the FMGE exam. Yes, this is the one with the reservoir bag is called as NRBM, non-rebreathing. Sorry, this was asked in INICET, not in FMG. Non-rebreathing mask. Okay. What is the maximum flow of oxygen? 15 liter per minute, and maximum FiO2 given through this 66%. Okay. Okay. Number 5 over here. Can you see the number 5 over here? There is a ventilator. From the ventilator, there are big tubings coming, and there is a mask very tightly attached to the face. There are straps that are attached to the face. The mask is very tightly attached. Yes, very good in some. This is your NIV mask. Anyone full form of NIV? Non-invasive ventilation. Okay. Maximum FiO2, again 100%. Okay. So your HFNC, NIV and intubation will give you 100% of oxygen. Okay. And this one used in children, he looks like a space astronaut. Yes. So you will give oxygen. You can see it's coming from here and it is going into the helmet. So this is called as your oxygen hood. The sixth one is called as oxygen hood. Maximum FiO2 given through oxygen hood is 90%. Okay. Akash is asking, is BiPAP the same as NIV? Yes. So NIV is the form of ventilation that you're giving. BiPAP is actually a mode of ventilation. Okay. Your BiPAP, that is bi-level positive airway pressure. CPAP, continuous positive airway pressure. These are modes of ventilation that you will set on the ventilator. But the name of this instrument is NIV, non-invasive ventilation. Okay. Alright, so these are all my oxygen delivery devices, and the main question that they ask about them is the FiO2 of these all. Okay, okay, guys, we have the second lecture at 8:30. Remember that. Okay, now what are these classifications called as? Used very importantly, very commonly in anesthesia. Yes, so this first one is called as Malampati classification. Okay, now if in Malampati classification I have class 1, 2, 3 and 4, my most difficult anticipated airway is in which class? Anticipated difficult airway? Yes, difficult airway is in class 4. Okay, so this Malampati class 1, if you see, you will be able to see the uvula, the soft palate, hard palate, tonsillar pillars, everything. Okay, then Malampati class 2, you will not be able to see the tip of the uvula, you will be able to see, and the tonsillar pillars are not seen. Okay, in Malampati class 3, here you will be able to see only the hard palate and the soft palate, and Malampati class 4, only the hard palate. You don't need to go too much detail. They will just ask you the name of the classification and they will ask you the use of the classification. So it is used for anticipation of airway. Okay, so it is used for airway examination. Malampati class 1 is easiest airway and Malampati class 4 is difficult airway. Okay. Now second grading. What is the name of the second grading? Yes, this is Cormack and Lehan grading. Okay, this is our Cormack and Lehan grading. So in Cormack and Lehan grading, this is seen on laryngoscopy. For this, you need to do intubation in the patient. So this can be done only after giving anesthesia. So if I am doing laryngoscopy, I see this full epiglottis, I see the arytenoids and the full length of the vocal cords. That means it is grade 1. If I see only posterior part, posterior 1/3 of the vocal cords, it is Malampati class, Cormack-Lehan grade 2. Okay. If I'm seeing only the epiglottis and the arytenoids, no part of the vocal cords seen, this is grade 3, and grade 4 may nothing is seen. So tell me, intubation will be easiest in which grade and most difficult in which grade? Which grade of Cormac Lehan easiest intubation and which grade most difficult intubation? Yes. So easiest intubation will be in grade 1 and most difficult intubation will be in grade 4. Okay. Now, next thing, can you identify these maneuvers being done in the patient? So, identify maneuver 1, maneuver 2 and maneuver 3. So, first, yes, very good Ashutosh. The third one is called as Selix maneuver. What is the other name of Selix maneuver? Other name is cricoid pressure. Okay. So what are you doing in this? You are basically pressing the cricoid cartilage. Can you see in this picture over here? When you press the cricoid cartilage, you are pressing the esophagus also. So this is done in rapid sequence induction. Rapid sequence induction. Now, when is rapid sequence induction done? When you're giving anesthesia in a patient who is full stomach. Okay. So if any food is there in his stomach, that will come up like this in esophagus under anesthesia. Now, when you compress the esophagus, the food will not go from the esophagus to the trachea. So you can prevent aspiration pneumonia by giving Selix maneuver or cricoid pressure during RSI. Okay. Second one over here. What is this called as? You're putting a needle into this area, cricothyroid membrane. Feel for the most prominent part of your neck, that is thyroid cartilage. Then there is a dip. Below the dip, you feel for a ring-shaped cartilage, that is your cricoid cartilage. So in between cricoid and thyroid, you will feel a dip. That dip is your cricothyroid membrane. So in emergency airway access, you can put a needle through that cricothyroid membrane and oxygenate the patient. So this procedure is called as cricothyrotomy. Cricothyrotomy. Okay. So here it is used for emergency airway access. Bala Sahib, you can buy any of the iconic courses. That is very useful. And when you buy the course, you can use my code Dr.Jhanvi Live, and that will help you get a 10% off on your subscription. All right. Okay. If you have, yeah, oxygen source and cricothyrotomy, you can just connect it to any flow meter which is giving oxygen. Okay. And you can give oxygen to the patient through jet ventilation. All right. What is this procedure that you can see in number 1? Yes, very good, Ashutosh. So this is called as fiber optic bronchoscopy. Okay. Anyone, when do I do fiber optic bronchoscopy? Any idea? Okay. So imagine I am having a difficult airway. Suppose my patient's mouth opening is only so much. Okay. The laryngoscope cannot go in, tube cannot go in, nothing can go in. So I pass this thin tube, which is a fiber optic bronchoscope. It has a camera over here. I pass it from the nose down into the oropharynx and into the trachea. Once it reaches into the trachea, on top of this tube, I will pass the endotracheal tube. Okay. So the endotracheal tube will go down and it will come and stay in the trachea. Okay. So this fiber optic bronchoscopy is done in anticipated difficult airway. When there is no mouth opening, when there is some fracture of the mandible, some problem is there over here, I will use fiber optic bronchoscope for intubation. Okay. Now this is also used for awake intubation. Instead of giving anesthesia and intubating the patient, if I want to intubate him awake, then I can do it by doing a fiber optic bronchoscopy, because it is not painful for the patient if I pass the small fiber optic bronchoscopy. Okay. All right. The last thing that we have to do in the first lecture for today is these positions. These positions were asked during your FMGE exam last year. So I want to discuss all the positions with you. So tell me, what is the name of this position? It is used in obese patients. What am I doing over here? I am placing pillows under the head so that the tragus of the ear and the sternal notch are in a straight line. What is the name of this position? Yes, very good. This is called as ramp position. I am creating a ramp, a slide, okay, slope. This is called as your ramp position. It is used in obese patients for intubation. Okay. What is the second position over here? Just under the shoulder, I'm putting a pillow, and here, so that I angulate the head. This is the position used for intubation. And it is also the position used for tonsillectomy procedure. Yes, very good. It is called as rose position. Then the second name is barking dog position. Whenever a dog barks, ऐसे करता है ना वो भाव भाव. So head is like that. Barking dog position. And third is sniffing the morning air. Sniffing the morning air. Okay. All right. This position, patient is on one side. I'm shifting the patient to the recovery room. Any idea what is the name of this position? No, this is called as the recovery position. Why am I shifting the patient like this, one-sided? If he has any secretions or vomit in his mouth, he will vomit it out like this. Instead of, if I shift him like this, he can aspirate the vomit, okay? So instead, I will shift him one-sided, so vomit will go out like this. All right. A position, position A is called as supine position. Very good. Most of the surgeries are carried out in supine position. Position B, head is going down. All the blood will go down to the brain and to the, it will cause rise in the ICP, rise in intracranial pressure, rise in intraocular pressure. Is it Trendelenburg or reverse Trendelenburg? Head down is Trendelenburg position. Okay, ulta of this, head is going up, feet are going down. Yes, this is called as reverse Trendelenburg position. So in which position will my IO, intraocular pressure and intracranial pressure be high? My intraocular pressure and intracranial pressure will be high in the, yes, in the Trendelenburg position. Okay, this position mainly used for gynec surgeries. Yes, it is lithotomy. And in lithotomy position, what is the nerve that is most commonly injured? The one that is present here on the lateral half, that is your common peroneal nerve. Okay. What is this position called? The patient is lateral over here. Is it right lateral or left lateral? It is lateral position, right or left? Whatever side is down, uska. Okay. So this is your right lateral position. Okay. In F, same lateral position, but you're giving a break to the table over here. You're giving a bend here so that this part comes up. So this is called as your kidney position. It is used for kidney surgeries. This part will come up. Okay. Alright. G is also kidney position. What about H? Patient is completely ulta. What is this position called? Prone position. Very good. And prone position mein, what is the most important complication that I'm worried about? Most important complication I'm worried about in prone position? Yes, eyes can get injured. Okay, so eye injury very common in this. And finally, in what is position I? Sitting position. What is the other one name? Fowler's position. It is also called as beach chair position. So it looks like he's sitting on a chair on the beach. Okay. What is the problem with sitting position? Complication? Yes, your most important complication is venous air embolism. Okay. So the air will enter from here, from the brain, because mostly sitting position is used for neurosurgery. It will go down to the internal jugular vein to the heart, and it will cause a venous air embolism. Okay. So what all have we covered in part 1? All the different positions of anesthesia, all the airway procedures, all the airway tests, all the oxygen delivery devices, all the circuits, everything about the machine, then parts of the machine, all the airway devices, endotracheal tubes, laryngoscopes, and LMAs. Okay. So in second part, we will mainly talk about the drugs in anesthesia and also the regional anesthesia parts. Okay. Now, one more thing before you guys go is I want to discuss with you the difficult airway algorithm. This is asked in the exam. Okay. Difficult airway algorithm. So, whenever I am going to intubate a patient, how many maximum attempts of intubation should I take? Should I keep intubating the patient till the tube goes inside, or should I stop at one fine point? Okay, maximum number of attempts is 3 plus 1. Okay, that is 4 attempts. Why am I writing +1? This last attempt should be by the most expert or senior anesthesiologist. Okay. Now, if I am unable to intubate the patient after 4 attempts, what is my next step? What is my next step? If I am not able to intubate, I have to maintain the oxygenation of the patient. Patient saturation is going down, 90, 80, 70. What am I supposed to do? No. Next thing I will do is I will try to insert a LMA or laryngeal mask airway. Okay. So when I try to insert a laryngeal mask airway, how many times can I attempt a laryngeal mask airway insertion? Yes, maximum I can attempt laryngeal mask airway insertion 3 times. In those 3 times, I can change the type of LMA, change the size of the LMA, all of that. Now, LMA is also not going in and saturation keeps dropping. 50, 40. Tell me quickly, what should I do? Patient saturation is falling. How do I oxygenate? Very good, Amodini. So, I will simply face mask ventilate. Hold the mask and press the bag. Okay. So, I'll simply do face mask ventilation in the patient. Okay. Now suppose this has also become impossible. I'm trying to ventilate, but the air is not going in. There is bronchospasm, laryngospasm. The entire area is bloody. What is the last attempt that I can do to oxygenate my patient? Yes. So I will do something called as front of neck access. I know my trachea is here. So I will try to access the front of the neck by 2-3 things. One is either if I have a surgeon, I can do a tracheostomy. Okay, so put a tracheostomy tube from the front of the neck. If I don't have a surgeon, take a wide bore IV cannula, like a 14 gauge IV cannula, and put it through the cricothyroid membrane. So that is called as cricothyrotomy. Okay, so this is my difficult airway algorithm. How is this asked in the exam? They will give you a situation. You have tried to intubate a patient 4 times. It has been unsuccessful. What is the next step you should do? Put LMA. You have tried to intubate patient. Put LMA in the patient. What is the next step you should do? Face mask ventilation. All 3 steps have been tried. Nothing is happening. Patient is not getting oxygenated. Saturation is falling. What should you do? Do a front of neck access. Okay, clear? So this is your difficult airway algorithm. So with that, we complete the part 1 of anesthesia revision. The next part starts at 8:30 and I will see you quickly guys over there. Don't forget at the end of the class to you can download this PDF and use it for your revision. That is the best part about special classes. Okay. You guys can download it from here only at the end of the class. Okay. I shall see you guys at 8:30. Bye bye.